I think the key messages from my presentation just now are first of all that we are under-treating our patients. We're under-treating them because many of them are not even diagnosed. So we've got to improve awareness. Once people are aware of treatment, we then, of their condition, we need to treat them. And then we've got to get more aggressive. We are not using enough drugs. Monotherapy is invariably inadequate. Most of our patients will need 2 drugs, and the guidelines are now saying start with 2 drugs. If that's not enough, you go to triple therapy. The guidelines all agree what they should be. And then you add in a 4th line, spironolactone, then maybe an alpha blocker and a beta blocker. So you've got 6 good agents in order to get the blood pressures controlled. We need to do that to get better control of blood pressure around the world. 2 or 3 bits I mentioned in my talk that are new. One is a trial with a thiazide-like diuretic, chlorthalidone, in patients with advanced kidney disease. We struggle controlling blood pressure in that setting. You can't use thiazides, but the thiazide-like diuretic in that setting lowered the blood pressure significantly. So that's a really useful bit of extra in our armamentarium when we've got CKD patients that are uncontrolled. The other thing that's been relatively new is a big debate about when we should take the tablets. Some data have suggested that we should take blood pressure lowering tablets at night because you get big cardiovascular benefits. I think most of us don't believe those results. I don't think they believe that approach. And this year there are 2 big trials coming out, BedMed and Time, which will settle that issue. Should we give the tablets at night or not? We should give tablets that give 24-hour blood pressure control. No one argues about that. But should they be taken before you go to bed or when you get up in the morning? That is not decided. And for the moment, we're going to have good data this year which will settle that argument. Lots of things are to come. I think taking a global view, it's putting what we know into practice, getting good, cheap, effective drugs to all the people who need it, and they should be able to take them. And that will, I think, move towards single pill combinations of drugs to improve adherence. But in the end, it's the cost of these products and the ability to get that around the world. The vast majority of patients are not in Europe. They're in the Far East, they're in Africa, they're in the South Asian subcontinent. We've got to get the drugs out there. And of course, before that, as I started off by saying, we've got to make people aware. So we've got to screen for raised blood pressure. And May Measurement Month will be happening again this year. Anybody who'd like to get involved, please have a look at our website and get involved with May Measurement Month.